probably tell me to ask you.
I'm Julie Parker. I'm one of the assistant directors of the Blueprint. I've been on Blueprint about 4 years, and previous to that, I worked at 2 designated agencies, and that's sort of my background.
Super. I think we can move to the second slide.
I talk
Oh,
pretty,
thank you
I
for-
talk pretty loud, and so I didn't want to blow anyone's eardrums out, so I moved it a little away.
And can the people online hear us? I imagine they can, because I'm quite loud too.
That's what they're monitoring for us outside the room, so I think we're
We're good
okay.
to go. Great. Well, when I started in January of 2022, there was already quite a bit of work going on in one of our legislative committees, Senate Health and Welfare, to give me a project. And I think the language is laid out quite clearly here. It's a very steep learning curve to enter state government or the VA or any extensive, long-standing system of our institutions. And it's also to add on something as specific as this was a considerable amount of learning too in just a short. I think we had about 6, no, I guess we had from June, I guess, until January to determine the amounts by which health insurers and Medicaid increase the per member per month payments towards the Blueprint Community for Health teams, which Julie has spoken about, and I'll get a little bit more into community health teams in the early slides for those of you who need that reorientation, and also quality improvement, how much to increase quality improvement work that's been part of the Blueprint from the beginning, and to do that within the setting of primary care services to Vermonters. So that was a pretty clear charge, and it was became really our charge then in June of last year to figure the answer out to that question. If we could have the next slide, please. Julie, I think
Yeah.
just
Just wanted
back.
to share some information just around some national statistic and then a statistic for Vermont. So one of the things we know is that 1 in 5 U.S. adults live with mental illness. We also, look at our Vermont Youth Risk Behavior Survey, and these numbers are pretty significant. 29.6, 17,224 youth identify feeling sad, hopeless for 2 weeks or more. 12.1% or 16,349 Vermonters identify drinking. This is again our Youth Risk Behavior Survey, 4 to 5 drinks at least one of 30 days. We also know that Vermont has one of the highest rates of suicide deaths in New England and the 18th in the nation as of 2020. So, that's just a snapshot of some statistics that are pretty significant in terms of why we feel, and I think our governor, our secretary, our state feels that we really need to be ensuring that we're supporting Vermonters the best we can. So one of the ways we do that is through our patient-centered medical homes, which meet the standards of National Committee on Quality Assurance and have community health teams embedded within primary care. And we know that a variety of folks within primary care can be supportive. So we've got some community health workers, we have dietitians, we have social workers, we have clinical mental health counselors, psychologists. And so we know that those teams can support our patient-centered medical homes. And again, one of the goals of this work is expanding that. We have worked hard with some folks to get an updated map on our website. So if you're curious to take a peek at that, we have 123 medical homes across the state. And here's the legend for that. So if anyone would like to go and take a look at that, there is a link to the list, but we wanted folks to be able to interact with a map, and that had been also a request to have an interactive map within our website.
Yeah.
Yeah.
One of my first questions really for myself and my team when I began to take on the role is, what is the composition of our community health teams? What has guided the community health teams beyond the local control? I knew that in theory, but I wanted to know in more detail, what are they composed of in terms of people? Who are these people? What are they doing? And how long have they been doing their work? And is the composition of the community health team the right composition? Is it in keeping with what people need? Is it swayed one way, the other way? Does it vary? Are there trends that we could look at? And with our program managers who are dispersed across the state, Julie, our other assistant director, Mara Donahue, and I visited all of our health service areas in person. I think -1 for me when I was sick, but I think every single community health team was invited to meet with us. So we were able to put faces, names, and stories to information that we collected from them that you're seeing summarized in front of you here in terms of their roles, whether it's care management, which includes care coordination and brief counseling, whether it's panel management, a term I probably did not know 20 or 25 years ago, but it's certainly a very important role to look out over populations. Some of our community health team members are involved in oversight of their colleagues and administration. That's certainly an important part of development and maintenance of a good team. Health educators, that part didn't surprise me that much. And registered dietitians and nutrition specialists. And then the second question we asked ourselves, and you can advance the slides at this point, is how many of those care managers are, on the left, you see the actual distribution by staff. On the right, you see the distribution in terms of FTEs. How many of them are licensed mental health counselors or social workers? And I was, I didn't have a right answer going into this. I didn't really know what the right answer was, but I was struck that my sense going through the state was this number seemed small to me. It seemed for a population that's probably greater than 70% of Vermonters are seen in a Blueprint patient-centered medical home. My sense was that maybe there's some portion of this that's not in balance with what people's needs are. And I was able in the coming slide to try to begin to compare that to the stories that I was hearing from the multiple people that we spoke to and I spoke to. So some of our goals, and I'm going to switch back and forth between our assessment of the situation and some of our goals, we're very clear in terms of what we wanted to do. We really wanted to minimize, and we still want to minimize, the number of people who have contact with their patient-centered medical home who go on to commit suicide or go on to have a death related to usage of substances when perhaps it might have been preventable if there was an opening to discuss it or find out about it during a visit. And that to me is very much the way I put the value of screening and brief intervention into my own sort of terms is the feeling of being a provider and knowing someone was in the midst of whatever the clinical setting was and a need wasn't unearthed. That's one of our goals, is to decrease the amount of times that happens, because it's still happening. And to answer the charge from the legislature to increase the amount of money that's put into the community health teams. The community health teams have not had an increase in their funding since 2015. And since 2014, our community health team numbers have dropped. From in 2014, there were over 140 full-time equivalents. Now we have less than 120. So there have been changes that have happened in almost 10 years related to the ability to staff and a plateau in terms of the number of dollars that have flown, and to better utilize quality improvement facilitators who, for the most part, are really focused on what the practice needs, what the needs of the National Committee for Quality Assurance are, and to expand their scope to mental health, to substance use disorder, and to best practices in the patient-centered medical homes that really integrate those areas of care more fully into the daily practice of the sites. Lots of different inputs. And I think Deputy Commissioner Cromp, I really appreciated what she said in terms of we are asking the questions, we are hearing, we as the leaders of these programs and of these large either programs or departments, agencies, we're engaging directly to hear, to summarize, to take notes, to listen to, whether it's groups like the Green Mountain Care Board, whether it's partners through the American Academy of Pediatrics or by state or Vermont Medical Society, down to Vermont Care Partners, designated agencies. This Integration Council, which I've attended as best I can and listened in and participated in the pediatric group, Julie Parker, who's been a leader really from the beginning to participate and to look at previous reports that have come out. For example, the Substance Use Disorder System of Care Enhancement Project that was published before the pandemic was starting, and to speak to providers, care managers, social workers, mental health counselors, broad members of the community health teams, health educators, and coaches, and to do this through every single part of our state, so that whether it's the Northeast Kingdom, the Northeast Kingdom, the Southwest, it's a very much a yeah, you just go. And it's of great meaning to those teams and their leadership and their providers to hear from leaders from the state who show up in person and spend 3, 4, one time over 6 hours with them, because they want to fill your day with everything going on in their community, to meet them and to hear their stories. And I'm gonna, and think in the next slides, try to summarize some of what some of those were. And I think that while the bullet points here may not surprise you, that the top 3 in terms of challenges: prolonged wait times for specialties, resource limitations, high rates of mental health concerns among patients of all ages. For me, especially in that first year, hearing about it in person and validating that and being able to reflect, well, we were just in this community, or we were just in that community, and we're hearing those things too, or that's something we have been hearing, and how are you working with it? And it is that in itself, at least as a first step, in my first year as executive director, that was very much part of the work, was to listen and to hear it and to validate it and to be there in person, so that you'd hear those very specific stories, some of which were incredible jaw-dropping successes in terms of being able to steer one's life in a completely different direction that I had never imagined. And others were very much consistent with the worst things you couldn't even imagine. But to listen to their stories and hear about the challenges that they're having, aligned with what we have been hearing and seeing in terms of waiting for specialties, appointments, and high rates of mental health concerns. And then the requests being more access to primary care, more support for primary care, adding funding to primary care, to breathe new life into community health teams. These are many members of community health teams across the state. Remember meeting our leadership, remember when the blueprint started, are very proud members 10+ years into the fold of their work. Similar to the peer specialist who we heard, this is my work, this is my calling, this is what I will do to remain. And then more specifics around specialty support with medication management, for example, alcohol use disorder or psychostimulant use disorder, and the successes that they saw of the medications for opioid use disorder, and the desire for those types of models of support, care, education, and training to then be applied to other areas of substance use disorder, or perhaps even other areas of mental health. Next slide. I know I tend to get more verbose than I realize, so I'll try to keep moving.
I was just going to also reflect
Yes,
on all of our visits to the state. It was interesting in 2 of our health service areas that are really, touch each other. They really made it clear, like, we are not that community, and they're not our community. And so we were like, okay. And they were like, don't compare us, view our communities as different, because our needs are different. And so it was very interesting to really visit everyone where they were and to talk about that. So
yeah. Or to be in St. Johnsbury and to be told very seriously, we are the Burlington of the Northeast Kingdom, and then the next week to be in Burlington and be telling leadership, that St. Johnsbury feels they're the Burlington of the Northeast Kingdom, and the reaction that you get in the room to hear something like that. Yeah, no, there's lots of compare and contrast stories that make the miles worth it. So the needs that we heard, staffing for community health teams, community health workers were mentioned specifically in our health service areas as we traveled. More access to counselors and social workers embedded within primary care, as we've seen within the Blueprint program and within other states, so that when a concern comes up that goes beyond navigating someone to the right services, that there's someone there to have a more in-depth discussion and assessment with them. Education, as I was saying in our previous slide, for substances beyond opioids, and for prescribing and treating conditions that I had people confide with me that our provider just won't write for an antidepressant, or they just won't write, they just won't. And to hear those things from people and say, but I think if you did this, this, and this, I think I could get them there, so that they would actually hold this person who has rather stable illness in that regard, receive their care and their medication here, rather than filling up more space and time for someone who, in my, I'm speaking as if I'm them, in my clinical opinion, really does need that extra specialty look. The screening and support of treatment around mental health, not just substance use and mental health, but also social determinants of health, work that Blueprint really has been doing and has been founded on. The community health teams are very much designed to complement the requirements of the patient-centered medical home, and they are an investment in people being connected to resources that may address food insecurity, housing instability, educational needs. That's just something that they've been from the beginning. And we also had the opportunity, and there's a session coming up right after that I'm not going to say too much about, because actually their leaders are here, but to learn about the developmental understanding and legal collaboration for everyone, Dulce, a specialized program that the Department of Health has overseen and been a part of, to really look at the specialized needs of families of young infants, our very youngest, the 0 to 6 month olds, and to learn about that program, and also to understand its needs to be sustained both by funding and oversight. So that's something that you all, I think, will all kind of move through. And then I think I've already said this about quality improvement facilitators, but to really elucidate more clearly to practices the transitions of care for individuals with mental health and substance use disorder between specialty care and primary care, and to develop stronger relationships, or even just in some communities, just develop relationships of referral patterns back and forth, and agreements of when a person's in one setting versus another.
So as Dr. Torin said, we want to prioritize the efforts of screening for social determinants of health. I do see a spelling error, sorry about that. Mental health and substance use disorder. And in doing that, really improving our identification and support of those for more than 70% of Vermonters. So really key universal screening. We'll talk a little bit about our work groups in a few slides, but our program design work group, and some folks in this room are members of that, we're really digging into our universal screenings and what we're hoping we can do for the whole age range, and no wrong door of folks, of parents, of caregivers coming in and ensuring we're addressing and asking those really important questions.
So we went to the legislature with a large ask for a 2-year pilot of for the community health team component of it, $5.98 million on the expansion of community health teams. As Julie said, there are 4 work groups going on right now to prepare for the possibility that actually might be passed and funded. So we're doing some of the work and the engagement of a broad audience over what Dulce's incorporation into community health teams and our partnership with the Department of Health might look. Community.
Because since my last serious concussion, I've had some pretty
Thank you. Sorry about that.
So we're very much open to participation for members of this group, and this information's on our website. There's no reason why you can't join, participate, or follow along with notes or give input. Still, and looking at program design and community health teams, a group that Julie's leading that's very much digging into what we're doing right now around screening, what can be modeled and held up as a best standard for them to be adopted more broadly. What will be the measurements and evaluation of this 2-year pilot, and then what will be the payment structure of it. The investments that we're proposing are towards community quality improvement facilitators who would focus more fully across the state in mental health and substance use disorder, creating the alignment and the workflows that we'd like to see really rise up. And on community health teams, that dollar amount that we would be able to disperse to community health teams would be focused on personnel who had expertise in mental health and substance use disorder to really more fully complement and round out those community health teams, that pie graph I showed you at the beginning, as well as incorporating, if it's what the area determines it needs more of, the possibility of more community health workers in community health teams too. I believe if we reel back to the slide, I believe right now across the state, there's only, is it 4 community health workers who are funded by the community health teams? 9% or 4 people.
4.8.
Yeah, so to give teams the resources for that level of team member in greater numbers than there are now. And there's a great, in my learning and reading and listening, there's really a strong continuum between community health workers and peer support that I believe if we can rise both up simultaneously as partners with DMH and within AHS and with Department of Health, I'd really like to see both become stronger and have more structure for education, and whether it's certification or something else in Vermont. I do believe that's an area where we can build on what's been begun here, and then also create a more consistent funding stream and opportunity for that specialized care in the youngest families and infants. I think I will pause because I've been speaking very quickly and got to the end of our slide.
Yeah, I was just going to note
Yes,
also
please.
for the work groups, all of the minutes of those are actually on our Blueprint website. So if you wanted to take a look at one and, just out of curiosity, and if there are things that you wanted to give feedback on or just make a note and send it my way, happy to have that feedback as well.
And there's several people in this room who are on a number of things.
Any questions?
Sure.
Yeah.
Absolutely. I know we're right at time, Kathy, right?
We are.
We're happy to answer questions.
Sounds like you're all day.
Here.
Can't leave.
We're not going
Alexis,
anywhere.
Hi, yes, John, I was wondering, so where do you see the peer as valuable in your
Tremendously. I think the emphasis with the dollars we're receiving based on what our community health team composition is now will probably be more weighted to community health workers in Blueprint funded positions. At the same time, people on my team like Julie and also myself follow, track, and support efforts to increase peers through the Department of Mental Health, through designated agencies, through CCBHCs, and also already peers are working in medications for opioid use disorder settings, the so-called spokes. So in terms of the round sort of swell for us in those medical homes will be around community health workers, at the same time that we very much keep our eye on and try to support the development of peers more broadly in the state, but don't take the lead on it to the same extent that we really have responsibility for community health teams. Is that a?
Yeah, no, I think that's accurate. We know Department of Health is doing a lot of work on that around training. And, I think they're looking to all the things we heard from the VA today. And so I think we're really allowing them to take the lead as they are doing. And then we'll come together and
We all have a question.
Well, first also, a statement. So we, over the past 10 years or so, have proven both the concept of peer support and the efficacy of it. I think it's important to reframe this conversation that it's not that we're trying to understand what is peer support or doesn't work, but that we have invested with state and federal dollars for a decade and at least a dozen programs in Vermont that are doing this very effectively currently. And we really have a question of if we would like to bring it to scale. And a lot of that has to do with what type of support we can provide for people in those positions and what type of support we can provide in those organizations to be able to really get it to that next level. One of the things that I would really caution us not to replicate is the financial errors in our system associated with substance use disorder recovery work. It's a life-saving, incredible support system, and we should be proud of it. And at the same time, you cannot find a person doing peer support within the SUD milieu who's making a livable wage or having adequate benefits. And almost the entirety of the organizations that are providing that modality do not have the essential financial infrastructure to really maintain their operations. So just a caution that we want to be very careful not to be extractive in this process. This is a value add. And then as we expand this across the system of care, we have an opportunity, and I would say an obligation, to also support those organizations to be more efficacious and to build supports for that workforce to really be able to sustain their career for long. So that's quite a bit of asterisk, sort of editorial, but I guess I would just say that it's not can we do it, but like we want to do it and we should do it in a way that actually will set everything up for success.
Agree with that. Yeah.
Yes,
I'm just wondering, can you talk a little bit about the Blueprint's role for integrating universal screening and the tool that your work group is currently working on?
so could you repeat that just in case people online didn't hear about?
Sure. So, how are we integrating universal screening and what is the tool that we're using? So it's multi-layered. So let me stand up. So part of the program design group one is to look at what are folks using already. And there's a variety of things people are using. We do know most commonly folks are screening. We did a survey last summer of primary care sites, and we know primarily folks are screening for housing, food, interpartner violence, utilities, employment. So there's some core screenings that we're finding everyone's using. And we want to augment that. So that is the discussion in the program design work group. So 2 weeks ago, we talked about adult screenings. This Thursday, we're talking about caregiver screenings, family screenings, and looking at dulce screenings and other, adolescent and youth screenings. So it's evolving. But I think some core screenings that we are talking about are PHQ-9, Columbia suicide screening, anxiety screening. And again, we're going to hopefully do that within age ranges and what's best recommended. There is a health needs screening that's suggested by Medicaid, Centers of Medicaid. So we are looking at that. And those questions are again around housing, food, partner violence, those kinds of things. So it's going to be a mix of things, but evidence-based screenings that people really feel makes sense, and a timing of that. In our group, we have some providers that have concerns about screenings and how are we going to get those screenings done right off, and how do we hand them off to the community health team? So part of it is once we land somewhere, really talking about those workflows and how those things are going to happen. Is that helpful?
Yeah, thank you.
Okay, sure. Yeah, I'm happy to send you a spreadsheet of the things we're talking about if you'd like to give me your name and.
I'll follow up.
Sounds great.
Yeah.
So how, I was listening to everything that you're doing. How are you factoring in, or pulling in equity issues and access issues while you're doing all this? And screening, things like that, because there are definitely differences in things that are happening.
So I want to make sure that I understand the question. So are you asking how will we make sure everyone does get screened or equal access to screening?
No,
Or
I'm asking about issues around diversity, equity, inclusion. How are you measuring? Why are you measuring? Because we know that a lot of the equity issues that exist and affect health equity get hidden because of HIPAA and other numbers, you've got to figure out a way to start counting people. Is that a conversation you're having?
I would say we need to have more of that conversation. Yeah, absolutely. And I'd love to talk more about that and your thoughts on that.
Sure.
Yes.
It's very exciting to hear about how they expand and where the services will go. I'm curious, and this is a point of my ignorance, is Vermont a state where Medicaid covers peer specialist services directly? And will that be a part of the sort of sustainability of what you're proposing? And if not, is there advocacy going on to make that a covered service through Medicaid?
So that is where I would say Deputy Cron. And so I think that DMH is doing a lot of work around that. Can it be billed? Where's, if I'm correct, where would funding come from? Things like that, I believe is something that's at the table. So we're not necessarily at that table around peer discussion. I don't know if you want to say anything more where that's at in terms of that.
Question was peer certification.
And will Medicaid pay for peer support?
So we are going through peer certification. We are trying to build a peer certification process in order for Medicaid to pay for it. And so I think that's been this big debate is once you get into that lane, we've had some good conversations of when you're in that lane, you then have to deal with eligibility determinations and notes and all the pieces that Medicaid needs to go for it. But that also generates funding. So we still think there will be a spectrum of peer services that may not fall into that lane, but we wanted the lane to be able to draw down funds for lots of reasons. CCBHCs in particular will offer good reimbursement for peer services, but you have to be peer certified. So there was a study to Nicole DeWhite led that work, and she's come out with some recommendations from that committee. And I think it's in process. It's slow going, I think, for some people, and for some, they're concerned that it's moving really quickly and they'd like to put some more thought into it. So I would describe it that that's where we're at. And we're looking at kind of an 18-month implementation timeline.
I think our focus, as Dr. Sherry shared, is really that community health worker at this time. But I mean, we absolutely want to engage with peers, but we're taking the lead of our partners to ensure that there's a system of care and their system. Closely.
So we should wrap up now, but thank you both very much for that. I found that very helpful. What we're going to do now is hear, we heard an overview. We're going to go into breakouts in a few minutes to hear where you can circulate to ask questions about the CCBHC model, the Dulce model, the VAs using peers in primary care practice, how the VA doesn't, so we go more in depth on that, and community health workers. So we'll move all these tables and set up 4 stations. So we'll take a really brief break in order to do that. Before we take that break, however, I'm going to ask the hosts of those stations, of 3 of the stations, since we've already heard about the VA model, to please come up here and we'll hear a very brief overview of the Dulce model of community health workers and of the CCBHC model. We'll take a very short break, do a lot of chaotic table movements and set up 4 stations and then come back in and you can circulate freely, but we can talk a little bit more about that. So folks would come up, please. And I'm going to try to change the focus of the camera, or maybe I shouldn't.
You're gonna say. Okay.
Yeah, I think,
Maybe they just sit.
yeah, that's what I was gonna say. I think everybody, if I could just ask you to go to the table, I think that'll be the easiest.